Welcome to our video on the menstrual cycle and menopause. Let's get started. As the name of this lecture implies, we'll talk about various aspects of the menstrual cycle and menopause. Let's start with the menstrual cycle. The menstrual cycle consists of ovarian and uterine cycles which are interconnected to each other. The ovarian cycle influences the progression of the uterine cycle. The ovarian cycle consists of follicular and luteal phases, while the uterine cycle consists of proliferative and secretory phases. The follicular phase has a variable length, while the luteal phase always lasts 14 days. Menstruation itself is sloughing off of the stratum functionalis of the endometrium due to estrogen and progesterone withdrawal. Let's see a graphical representation of the menstrual cycle and discuss it further on the next slide. On the upper part of this illustration, we see an ovarian cycle, while on the lower part, we have the uterine cycle. During the follicular phase, GnRH produced by the hypothalamus stimulates production of follicle-stimulating hormone and luteinizing hormone. FSH and LH in turn stimulate the developing follicle to produce estrogen. Estrogen, in turn, stimulates endometrial proliferation, accounting for the proliferative phase of the uterine cycle. At the junction of the follicular and luteal phases, estrogen exerts positive feedback on FSH and LH, resulting in their surge. The LH surge results in ovulation, that is, rupture of the mature follicle and release of the egg. A remnant of the follicle forms the corpus luteum, which secretes progesterone. Progesterone, in turn, makes endometrial glands coiled and increases endometrial secretions, accounting for the secretory phase of the uterine cycle. Finally, the corpus luteum degenerates into the corpus albicans, ceasing progesterone and estrogen production. The rapid drop of progesterone and estrogen causes sloughing of the stratum functionalis layer of the endometrium. Therefore, the woman experiences bleeding. All right, with that brief review, let's move on to discuss menopause. For menopause, we'll be discussing its definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. Menopause is amenorrhea for at least 12 months. The average age of onset is anywhere from 49 to 52 years of age, although it can happen earlier, and one of the high-yield points to remember is that it can happen earlier in smokers. Let's discuss a related term, perimenopause. Perimenopause is the time from the first appearance of menopausal symptoms to 1 year after menopause. An average duration of perimenopause is 4 years. Okay, moving on to the pathophysiology. The number of ovarian follicles decreases with age. Therefore, estrogen and progesterone levels are low. Almost all signs and symptoms of menopause are due to estrogen deficiency. Additionally, loss of negative feedback disinhibits the hypothalamus and anterior pituitary, resulting in high gonadotropin-releasing hormone, follicle-stimulating hormone, and luteinizing hormone. Now we'll move on to the clinical features. Menopause is characterized by psychological symptoms like mood swings, irritability, anxiety, and insomnia. It also has autonomic symptoms such as hot flashes, heat intolerance, and increased sweating. These symptoms are very similar to those of hyperthyroidism. Therefore, hyperthyroidism should be ruled out with TSH if the patient exhibits these psychological and autonomic symptoms. One of the most common clinical features of menopause is genitourinary syndrome of menopause, previously known as atrophic vaginitis. The reason why menopausal women can develop this is that the vulva, vagina, cervix, and urethral epithelium are responsive to estrogen. In this condition, women have atrophy of the vulva, vagina, and cervix, resulting in dyspareunia. Additionally, they experience atrophy of the urinary epithelium, resulting in increased urinary frequency, urgency, and dysuria. Urinary incontinence can also complicate genitourinary syndrome of menopause. Other conditions associated with menopause are osteoporosis and coronary artery disease. Normally, estrogen stimulates osteoblasts and inhibits osteoclasts. Low estrogen levels, on the other hand, result in decreased osteoblastic and increased osteoclastic activity, causing osteoporosis. Women greater than or equal to 65 years of age should be screened for this with a DEXA scan. Coronary artery disease is another potential complication and can be induced by low estrogen, causing increased LDL and decreased HDL. All right, let's try a question. A 70-year-old woman is brought to the physician by her family due to upper back pain that started 3 days ago. She has a past medical history of a left distal radius fracture 3 years ago that was casted for several weeks. Her family has noticed that her height has decreased over the last 4 years. A DEXA scan reveals a T-score of -3.5. The physical exam reveals tenderness at the T8 spinous process. What is the first-line treatment option for this patient's condition? All right, this patient presents with acute upper back pain that started 3 days ago. She also had a distal radius fracture known as a Colles fracture. Her height has decreased over the last 4 years, and a DEXA scan revealed a T-score of -3.5. A T-score of less than -2.5 is diagnostic for osteoporosis. Acute upper back pain is most likely due to an acute vertebral compression fracture. A decrease in height is caused by multiple acute and chronic vertebral compression fractures over time. The first-line treatment option for a patient with osteoporosis is bisphosphonates, like alendronate, risendronate, pamidronate, and so on. Bisphosphonates inhibit osteoclast activity in the bone matrix, which preserves bone mineral density. Alternative treatment options include teriparatide, which is a parathyroid hormone analog, as well as potentially raloxifene, calcitonin, and denosumab. Okay, moving on to the diagnosis of menopause. Menopause is mostly a clinical diagnosis. However, we can check serum estrogen and FSH levels, which are expected to be low and high respectively. Total cholesterol, LDL, and HDL levels can be measured to screen for hypercholesterolemia. Finally, as we mentioned on one of the previous slides, the serum TSH should be measured to rule out hyperthyroidism. Okay, moving on to management. Since menopause is part of the normal aging process, treatment is not always indicated. Treatment is used only for patients with severe symptoms and decreased quality of life. It can also be used in cases of premature or surgical menopause. Types of therapy include lifestyle modifications, topical estrogen, non-hormonal therapy, and hormonal replacement therapy. It's worth noting that these treatment options do not usually result in complete resolution of menopausal symptoms. Instead, they delay the onset of those symptoms. Lifestyle modifications comprise the first-line treatment for menopause. Exercise and relaxation techniques can be attempted for impaired sleep. To prevent osteoporosis, the patient should increase vitamin D and calcium intake. Additionally, weight-bearing exercise can slow the progression of osteoporosis. Bisphosphonates are initiated only after the diagnosis of osteoporosis is made and not for prevention. Topical estrogen, on the other hand, treats atrophic vaginitis. Different formulations of topical estrogen include either cream or a vaginal ring. The most commonly used drug in the non-hormonal therapy category is raloxifene, which is a selective estrogen receptor modulator, or SERM. Raloxifene is used mostly to treat menopause-associated osteoporosis. Adverse effects include exacerbation of hot flashes because it blocks estrogen receptors in the hypothalamic thermoregulatory center. Additionally, raloxifene stimulates estrogen receptors in the liver, increasing coagulation factor synthesis. This in turn predisposes patients to develop DVTs, PEs, or stroke. Advantages of raloxifene is that there is no increase in the risk of endometrial carcinoma due to its antagonistic properties on endometrial estrogen receptors. This is in contrast to tamoxifen, which is a partial estrogen receptor agonist in the endometrium. Therefore, tamoxifen does increase the risk of endometrial adenocarcinoma. Now let's discuss hormonal replacement therapy in a bit more detail. Hormone replacement therapy, or HRT, is used only for short-term treatment of menopausal symptoms due to associated risks that we'll talk about in the next slide. There are two types of HRT. Estrogen-only HRT is used in women who have had a hysterectomy. This is because estrogen-only HRT significantly increases the risk for endometrial carcinoma in women who still have a uterus. Progestins antagonize estrogen in the uterus and prevent endometrial hyperplasia. This is why we use estrogen and progestin HRT for women with an intact uterus. Estrogen-only HRT can cause endometrial cancer in women with an intact uterus due to unopposed estrogen effects on the endometrium. On the other hand, estrogen and progestin HRT can cause breast cancer because both of these hormones stimulate proliferation of breast tissue and increase the risk for breast cancer. Contraindications for HRT include undiagnosed vaginal bleeding because this bleeding can potentially be coming from endometrial carcinoma. Breast and endometrial cancers are also considered to be contraindications because HRT will only stimulate their growth. If the patient has a chronic liver disease, estrogen and progestin will be insufficiently metabolized, resulting in their accumulation and adverse effects. Finally, a history of DVTs, PEs, or stroke are other contraindications because HRT further increases the patient's hypercoagulability. Okay, let's wrap up with a final question. A 53-year-old woman comes to the physician reporting pain during sexual intercourse. Her last menstrual period was 2 years ago. Her past medical history is significant for a deep venous thrombosis 5 years ago. She has not undergone any surgeries. Sometimes she feels intense heat arising from her chest and spreading to her face. Her vital signs include a temperature of 36 degrees Celsius, a blood pressure of 135 over 80 millimeters of mercury, a heart rate of 85 beats per minute, and a respiratory rate of 15 breaths per minute. The physical exam shows a dry and shortened vagina. Which of the following is the best treatment option for this patient? A. Vaginal estrogen cream, B. Estrogen-only hormone replacement therapy, C. Tamoxifen, or D. Weight-bearing exercise. All right, this patient presents with pain during sexual intercourse, hot flashes, and a dry and shortened vagina. Her last menstrual period was 2 years ago. All of these findings are consistent with the diagnosis of menopause. The patient's chief complaint is dyspareunia, which refers to pain during sexual intercourse, and this is likely due to vaginal atrophy. The best treatment option for genitourinary syndrome of menopause is topical vaginal estrogen. Therefore, the correct answer is A, vaginal estrogen cream. Recall from this slide that the treatment for atrophic vaginitis is topical estrogen, which can include topical vaginal cream or a vaginal ring. All right, now let's discuss why the other options are incorrect. Option B, estrogen-only hormone replacement therapy, is incorrect because it's contraindicated in women with an intact uterus due to the risk of endometrial carcinoma. This patient has not undergone any surgeries, which suggests that she likely has an intact uterus. Additionally, she has a past medical history of a deep venous thrombosis, which is another contraindication for hormone replacement therapy. Option C, tamoxifen, is also incorrect because this is indicated for the prevention and treatment of estrogen receptor positive breast cancer rather than for menopause. Additionally, tamoxifen can exacerbate hot flashes, predispose this patient to another episode of a DVT, and increases her risk of endometrial adenocarcinoma. Finally, option D, weight-bearing exercise, is incorrect because although it's recommended to prevent osteoporosis in postmenopausal women, weight-bearing exercises is not effective for vaginal atrophy, which is what causes dyspareunia, and this is the main complaint of this patient. So again, the correct answer is A, vaginal estrogen cream. And that concludes our lecture on the menstrual cycle and menopause.